All right, this one will be quick. It says part 1, but it's really just miscellaneous pediatric brain tumors. Dr. Tenenholz did all these lectures last year, and I adapted them. And so credit goes to him for a lot of these slides, a lot of the material here. So just probably could have done this first, but types of cancer in children, most of them are leukemias. Okay, we don't really treat these patients. These are the patients we treat: CNS, neuroblastoma, Wilms, soft tissue sarcomas. Okay, but leukemias, lymphomas we're also treating to some degree. Okay, brain tumors in general, most common solid tumors in children. Okay, second only to leukemia. Almost 4,000 pediatric brain tumors per year. Okay, I showed you this already. Distribution by age. Okay, the variability. Things like embryonal and PNETs, medullos are more common in young, and as you get older, they're less common. Pituitaries are more common as you get older. Okay. Age of diagnosis of different types of tumors. Brain tumors, again, most common in young age, up to like age 5, and they go down significantly. Okay. Survival rates based on pathology, okay, and based on age. PNETs at young age, infants tend to do this very poorly in general for any disease. Once they get past infancy, they tend to do better. Okay, these are good trivia questions for familial syndromes. NF1 is very important to know about. Optic pathway gliomas are associated with it. Malignant peripheral nerve sheath tumors, and neurofibromas. For NF2, if you have bilateral vestibular schwannomas, that's like pathognomonic for NF2. But they also have meningiomas, spinal cord ependymomas, spinal cord astrocytomas, hematomas. Okay, VHL associated with hemangioblastoma. Tubular sclerosis is associated with subependymal giant cell tumors, or SEGAs. I had never seen these until I was a Peds fellow, and these actually, I've seen a number of them. We don't tend to treat them, but in patients with tubular sclerosis, these are not uncommon at all. Li-Fraumeni is associated with PNET. These are P53 tumors. P53s with like medulloblastomas, these patients do very poorly. Okay, Cowden syndrome, Turcot syndrome associated with medulloblastoma, as well as glioblastoma. Nevoid basal cell carcinoma associated with medulloblastoma. This is associated with Gorlin syndrome, if you guys remember that. I actually had one patient 2 months ago, young child, 5 years old, found out that her mother had jawbone cysts. Looks like she has Gorlin syndrome. She has a medulloblastoma and sonic hedgehog pathway, but she had bad anaplasia. Anyway, if you give them radiation, you end up giving them a ton of basal cells. We decided not to treat her, but she's doing very well on chemotherapy because they tend to be very chemoresponsive. Okay. Tumors of infancy, they usually have features of intracranial pressure. Okay. Adolescents, they tend to have more like headaches, emesis, Paranode syndrome because of the germ cell tumors. You can have seizures if they're like supratentorial, often temporal lobe foci. Okay, by location, another distribution. Again, your infratentorial tumors are usually your medullos, ependymomas, brainstem gliomas, but also your astrocytomas, like even like your DIPGs. Okay, supratentorials, again, astrocytomas most common, and then a scattering of others. Okay. Symptoms are based on location. NF1, okay, this is very important. As I was saying, optic pathway gliomas. NF1 associated gliomas tend to be very indolent. If you have a hypothalamic, chiasmatic, optic pathway glioma in an NF1 patient, you just sit there and watch it. Okay? If they're developing neurological symptoms like losing vision, actively losing vision, then you can then consider treatment, but it depends how old they are. You want to hold off radiation as long as possible, and in general, try not to give radiation ever. They can do chemo with carbovincristine, and radiation in an NF1 patient is associated with moya-moya syndrome, like really bad vasculopathy. So we really try not to treat an NF1 patient ever. Okay? If they have an optic pathway glioma that's not NF1 related, perfectly fine. It's a completely different ballgame. They still try to do chemo and delay. You try to get them to around age 10 or later before you give radiation. Okay? Tuberous sclerosis, as I was saying, are associated with these SAGAs, subappendicular giant cell tumors, Li-Fraumeni tumors, a syndrome associated with brain tumors, and we know that radiation is related to meningiomas. Okay, so gliomas. So going along the same lines, we have our low-grade gliomas. And I'm going to go through this quickly because rhabdo and Wilms is more important. Okay. Pilocytics, most common. Okay. Cerebellar tumors. Oligodendrogliomas and other astrocytomas more seen supratentorially. Okay. Astrocytomas, grade 1 are the pilocytics. It's no longer called juvenile. Grade 2s are your diffuse astrocytomas or pilomyxoids, which act a little bit worse. Grade 3s are your anaplastics and GBMs, which you know about. Okay? Astrocytomas in kids are usually grade 1 or 2. They're usually midline. Okay? Grade 3s, of course, tend to happen more in adolescents. Okay? In young kids, less than 4, we usually give them chemo. Low-grade tumors, we give them chemo as well, radiation or both. Okay? High-grade is not really much different than it is in adults, except Temodar data in kids is really lousy. Okay, so histology, these are your different kinds. Pilomyxoid, again, are more aggressive forms of astrocytomas. There's also like your pleomorphic xanthoastrocytomas, your PXAs, which are also more aggressive. Okay, but these are just different types of astrocytomas. Okay. Here's your pilocytic astrocytoma. They tend to have loose honeycombed areas like this one over here, and also dense fibrillary areas like this. Okay, and they have their buzzword are the Rosenthal fibers. Okay, here's a picture of your posterior fossa pilocytic. This one causing some significant, actually has a big, huge fourth ventricle expanded. Very rare to have mitoses in a pilocytic astrocytoma. They're very not malignant. Okay, grade 2s, more aggressive, still low-grade tumors. Picture of your diffuse astrocytoma, WHO grade 2 over here. More MIBG staining in grade 2s than you do in your grade 1s. Okay, how do we treat these? We usually just do surgery. If they can get a GTR, it's often curative for these young kids. I mean, you already have your CNS section, so I'm trying not to go through very much. In general, very similar management with some exceptions that I'm trying to highlight. So yeah, GTR is excellent survival. If you have incomplete resection and radiation, they still get very good local control. Extensive resection, if you get it all out, they do very well. Okay, your low-grade astrocytomas, you can do this basically the same as you would for an adult. 50 to 54 gray is what we usually do in kids. The American study, the COG, goes to 54 gray with like a 5 millimeter margin. The Europeans use 50 gray. So somewhere in there. There's no dose response that we've seen. There was a study that looked at patients who had gotten 50 versus 54 and didn't find any difference. So in general, for the kids, I usually give them 50 gray, unless it's like a very easy to treat area, like very peripheral lesion, supratentorial. I might give it 54. But the ones near the chiasm, brainstem, I usually just stop at 50. Okay. With adjuvant radiation, they have very good local control. Okay, thalamic tumors with radiation alone don't do as well. Hypothalamic, they do okay. Okay, up to 6 months after radiation, you can still have some tumor enlargement, which can be scary. It's kind of like pseudoprogression, like with the GBM, but it can take longer because they're lower grade. Okay, so the young kids, carbovincristine is often done initially because we don't think you really lose anything by doing that up front, and it's safer than doing radiation. Optic pathway gliomas, again, 20 to 40% are NF1 patients, so we try not to treat them. In older patients, they can have visual disturbances, but in younger children, it'll be usually more symptoms associated with where they are at the pituitary hypothalamus, causing endocrinopathy, potentially increased intracranial pressure, and this diencephalic syndrome, okay, hyperactivity and low weight. Right, so this was an old hit protocol, which showed how they treated optic pathway gliomas, which I think is very reasonable approach. Okay. In NF1, again, median age is 5 years. Pathology is usually pilocytic. They can have vision loss. Pupillary reflexes are lost. Precocious puberty if the hypothalamus is involved. Okay, so we look out for all of these potential symptoms. We don't really give radiation unless we need to. So if they have like neurological features and vision loss, clear progression, we'll treat them if we need to. Okay, so picture of your optic pathway glioma. Okay, here's a much bigger supracellular tumor. Okay, they can get surgery if it's involving just one nerve. You can give radiation, which is very effective, but you have a second malignancy rate that can be pretty high. Okay, and in the young kids, carbovincristine. Okay, we just do local volumes. NF1 can cause severe T2 changes, as I was saying, and this can cause moya-moya disease, so particularly in NF1. So they can get really bad vasculopathy from the radiation and end up suffering more from the vasculopathy than they were from their tumor. Okay, grade 3 and 4 astrocytomas, I'll skip this. We treat them effectively similar to adults, but we usually use 180 centigrade fraction instead of 1.8 instead of 2s. Like for a pediatric high-grade glioma, I'll do 45 gray to my first volume, and then I'll boost to 59.4. Just give them a slightly lower dose per fraction, but still get to basically 60 gray. Temodar has not been effective. Okay, they use carbo, and so for high grade, they've used a lot of different things, and we don't get good results from them. Okay, I'm just going to skip through. Okay,